Hi, this is Dr. Mahadevan, and we're going to be moving on with our part 3 of our Advanced Airway Management series. And last lecture, we talked about preparation, pre-oxygenation, and positioning the patient, and also the level of the bed so that you could perform endotracheal intubation. In this lecture, we're going to focus specifically on placement of the endotracheal tube itself. So the first step in placement of the endotracheal tube is to position yourself at the top of the patient's head. If the patient has an oral airway, you want to remove it, and then you're going to open the patient's mouth with something called the scissors technique. You're going to get your fingers in there and twist your hands together, and that will open the patient's mouth. Then, holding the laryngoscope in your left hand, regardless of whether you're right-handed or left-handed, you're always going to hold the laryngoscope in your left hand. You're going to insert the blade into the right side of the mouth and sweep the tongue to the left. This is very important. Otherwise, the tongue can obstruct your view. Sometimes you can have an assistant pull the corner of the mouth out of the way, so that gives you a better view. Let's take a look and see what this looks like. So again, holding the laryngoscope in your left hand, using the scissors technique to open the mouth, as I mentioned, insert the blade into the right side of the mouth, and then you're going to sweep that tongue over to the left-hand side. Great. Then you're going to slowly advance the blade along the hypopharynx and lift the laryngoscope as you look down the blade. And eventually what's going to happen is you're going to see a couple things. That's the epiglottis, and these structures are the white vocal cords. So as you're inserting and slowly advancing the laryngoscope blade into the hypopharynx, you're going to see these structures. Then, very carefully, you're going to exert gentle traction at about a 45-degree angle to the floor to elevate the mandible and see the vocal cords. And so it's almost like raising a toast. You're going to lift that wine glass up to where the ceiling meets the wall. Very important. What you're not going to do is crank back or rock your hands back. If you do that and you use the teeth as a fulcrum, you're going to break the patient's teeth. And again, generally, they're so obtunded, they're so out of it, they can't tell you that you're hurting them. So it's up to you to make sure that you're using the proper technique. Again, raising a wine glass, you're going to lift up the tissues rather than crank back and injure the patient. Then, depending on what kind of laryngoscope blade you're using, that will determine where the tip of the blade ends up. If you're using the curved or Macintosh blade, you're going to insert it into the vallecula, and then as you lift up, you're going to also lift all the tissues up, and with those tissues, the epiglottis, and that's going to give you a view of the vocal cords. When using the straight or Miller blade, which is often used in pediatric patients who have large floppy epiglottises, you're going to position the blade below the epiglottis and then lift up. So you're not only lifting the tissues up, but you're lifting the epiglottis as well. And that's going to give you, again, a view of the vocal cords. All right, so when the laryngoscope is in the right position and you apply proper traction, you're going to see these white vocal cords. And once you see these vocal cords, you know where you want to insert the endotracheal tube. This hole right here is called the glottis, and beyond that, what we're looking at right there is the trachea. If you're having a hard time seeing that glottic opening, one of the maneuvers that either you can perform with your right hand or an assistant can perform is something called the burp maneuver. And the burp maneuver stands for backward, upward, rightward pressure. Backward, upward, rightward pressure. So you're going to push back, you're going to push up, and you're going to push to the patient's right. And in doing that, you may improve visualization of the vocal cords. And unlike cricoid pressure, where you're putting pressure on the cricoid cartilage, the burp maneuver is performed by grasping and pushing on the thyroid cartilage. So this is different. And I've used this maneuver on many occasions, and it's greatly improved my visualization of the vocal cords. Next, maintaining a clear view of that opening, the glottis, you're going to hold the endotracheal tube with your right hand, very important, and you're going to insert it into the right side of the mouth, and don't use this blade as a guide. You're going to come in from the side, as we'll see. Don't use the blade as a guide. Insert it through the right side. So let's take a look and see. So once you have the vocal cords visualized, as we do there, insert the endotracheal tube through the right side, through the glottis, and you're done. Very important, okay? Don't use the blade as a guide. Once you visualize the endotracheal tube passing through the vocal cords, which is very important, then it should rest just about 2 centimeters beyond the vocal cords. That's where you want the tip or the cuff of the endotracheal tube to reside, just about 2 centimeters beyond the vocal cords. A very important adage in endotracheal intubation and advanced airway management is as follows. If you do not see the vocal cords, never insert the endotracheal tube. It's very important to see the endotracheal tube passing through the vocal cords. That's one way that we know it's in the right location. So again, if you can't see the vocal cords, do not pass the endotracheal tube. So let's take a look. We've got our physician who's taking a look at a child who needs to be intubated. He's attempting to pass the endotracheal tube, but it's not, he's having a hard time seeing the vocal cords. So what should he do? Should he just pass it? No, never. He's going to take that endotracheal tube out, take his laryngoscope blade out, and begin ventilating the patient again, and get ready for another attempt at endotracheal intubation. Okay, very important concept. Once you see the endotracheal tube pass the cords, you can remove the blade, but you're not going to take your hand off the endotracheal tube. You're going to hold it with your right hand very securely, and then holding the endotracheal tube with your right hand, you're going to grasp the end of the stylet and pull it out very carefully without removing or moving the endotracheal tube. Then you're going to inflate the distal cuff with 5 to 10 milliliters of air. Okay, you're going to blow up that cuff, and then you're going to take the syringe off the inflation port. Then you're going to have your assistant attach a bag mask device to the endotracheal tube and begin ventilating the patient. And you're going to monitor the patient's chest to make sure that it's rising each time your assistant gives a ventilation. Again, endotracheal tube insertion depth is generally about 2 centimeters beyond the vocal cords. In most adult males, we say 23 centimeters at the lips. In most females, it's generally 21 centimeters at the lips. And the way you can know that is each endotracheal tube has markings on it of centimeter markings. And so when you look at it, once it's been inserted, you'll know how deep it is, and you can adjust it accordingly to 23 centimeters in males, 21 centimeters in females. In children, we use the formula 3 times the endotracheal tube size to know how deep it should be. So if we insert a 5.5 size endotracheal tube in a child, the depth is going to be 16.5 centimeters, which is 3 times 5.5. So in terms of endotracheal intubation, we've spent a lot of time talking about placement, a very important part of endotracheal intubation.